think so.
Okay, sir. Good evening, everyone, and welcome everyone. Thank you for joining us for today's Secret of Neurology. Today is a very precious day as we are completing the 2 successful years with this web series. And I am very thankful to our course director, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir. Under their guidance, this program has touched the new heights. And further to this, I am also thankful to all the audience who joined us in the last 24 episodes and encourage us with all the latest and the new topics and very encouraging topics of neurology. This program is widely accepted worldwide, and it's a privilege for me to introduce our course director. As today's program, that is, we are having a team of Bharati Vidyapeeth Pune, those who will presenting their case today. The case is very interesting, and we will close this session by 9:40 today. And it's a great pleasure to introduce our course director, Dr. Sudhir Shah sir, as Sir is a professor and head of department, NHL, MMC, and SVPI, MSR, Ahmedabad. Sir is a director of Neurosciences, Sterling Hospital, Ahmedabad. And Sir is a renowned personality and renowned neurologist of India. Sir has got the Padam Shri Award in 2016 and BC Rai Award in 2018. Sir is having an interest in stroke and neurodegenerative diseases and epilepsy. Welcome to you, sir. And further to this, I would like to introduce our second course director, Dr. Lakshmi Narasimhan sir. Sir is director and professor, Institute of Neurology, Madras Medical College, Chennai. Sir is the renowned personality of India and worldwide, and sir has contributed to the 9 neurosciences. He was their 3-time executive member in the Indian Academy of Neurology, and sir is the CME convener, Indian Academy of Neurology, and successfully organized 7 consecutive clinical neuroscience program. That is a SHINE. So, sir, everyone knows both the course director, and they are the renowned personality of India. So, nothing to waste much of our time. I'll hand over this session to Sudhir Shah sir. Sir, over to you.
Thank you. Thank you very much, Mr. Arun Chadda. Thank you for your unflinching support for this wonderful, very long-lasting webinar series that is Secrets of Neurology, Pulse of Wisdom. As you rightly mentioned, this is the 24th episode, so we are finishing 2 years. And I, myself and Dr. Lakshmi, both as course directors, thought that we should celebrate this. Let us have a prayer, lamp lighting ceremony. And I request Heli to start the process of Saraswati Vandana with lamp.
Rohit? Yeah, okay.
Shubham kurutvam kalyanam arogyam dhanasampadah. Shubham kurutvam kalyanam arogyam dhanasampadah. Shatru buddhi vinashaya deepajyotir namostute. Deepajyotir namostute. Shubham kurutvam kalyanam arogyam dhanasampadah. Shubham kurutvam kalyanam
let me recite Saraswati Vandana also. Sharda Shardam Bhoja Vadana Vadanam Bhave Shubham Karoti Kalyanam Sarvada Sukasannidhim Namostute. I, at the outset, want to uh, thank all the institutes who have done profound presentations in last 2 years with wonderful variety of cases, with lots of pulse of wisdom and lots of points to learn for students, for the practicing young neurologists, as well as for the seniors. So I myself and Dr. Lakshmi, we can't thank them enough for their wonderful pulse of wisdom. At the same time, I want to be very, very grateful. I want to express my gratitude to all the delegates who have shown tremendous affection, continuous support, and lots of interest in attending all these 24 webinars. And I am very happy to tell you that we have delegates from all across the globe. You'll be surprised to know that we have delegates from USA, UK, Spain, Portugal, France, Germany, also from the neighboring countries, UAE, Thailand, Sri Lanka, Maldives, and some other part of the globe. So this is the way, how people have appreciated this webinar series. Now, I also want to thank my co-course director, Dr. Lakshmi Narsingh, without whose endeavors and tremendous efforts, this program would not have been successful to this extent and this depth. Thank you, Dr. Lakshmi, for always being there and sorting out so many things for us. I want to thank Team INTAS, headed by Mr. Arun Chadda, and Dr. Haley, Dr. Manoj, and the full team for their terrific logistics support. I want Haley to play the video, the journey that we have done in all these 2 years. And at the same time, we want to promise that we would love to continue these monthly webinars for coming months and maybe years. It is possible that tomorrow somebody else may take up our place, whatever, but the show must go on. And I wish great success for this ongoing learning program. So let's have that video, Haley.
When the video is being played, I welcome any colleague who has expressed this in the chat box. Welcome from the colleague, neurology colleague from Pakistan. Listen to the chat box with love and affection.
Oh, wonderful. Yeah, from Pakistan. Wow, great.
Should I play, sir?
Please,
Yeah,
please. Thank you, Dr. Harry, for that wonderful video which you have prepared at a very short notice. I think in the afternoon only I talked to Mr. Chadda and requested if we can have the glimpses of our journey. Thank you very much.
Thank you,
So,
sir.
friends, we move forward. Let's have the slides for today's presentation. Who is yeah, so today we are having 24th episode, and we have the team from Bharati Vidyapit Pune. Dr. Anup Bende would be presenting the case as a senior resident of neurology. Next slide, please. Next slide, please. The discussant is Assistant Professor Dr. Dulari Gupta from the same institute, Bharati Vidyapit Pune. And next slide, please. And to commemorate this wonderful occasion, who could be the better person than our own Brigadier Dr. Shankar Prasad Gorti, our most beloved man from Army from a brigadier cadre. I mean, salute to you, sir, for being here and
Thank you, sir.
accepting our invitation at a very short notice. But as we understand that Army people are always used to someone at a very short notice, I'm sure you will all do wonderfully well. Sir is a professor and head neurology, Bharati Vidyapit Hospital, Pune, and very humble man. And he didn't want us to discuss a lot of his accolades and achievements, but in whatever short way I can, he's a professor and head, as I mentioned, and he had been recipient of ML Sony Award for Best Resident in Neurology in AIMS. Best Research Paper Award in Annual Conference of IAN, our Indian Academy of Neurology in 2001, as well as 8th International Sardar Patel Prestigious Award 2013 for Neuroscience Research. We all know these areas of interest: movement disorders, stroke, and stem cell research. And he has been a member of several prestigious national international bodies, IAN, NSI, IEA, API, ISA, WSO, and ISCM, etc. So before I hand over the mic, I stand very humbly once again in front of all of you for all your support, right from all professors and head. You have seen the stalwarts of neurology across the globe have contributed to this great webinar series, to students, the assistant professors, and of course the delegates, and all the supporting team. And above all, once again, I want to thank my personal friend, my co-mentor, the co-course director, profound man, Dr. Lakshmi Singh. And with that, I would like to hand over mic to Dr. S. P. Gorti, sir. Please.
Thank you, sir. Thank you very much for this wonderful experience. And on behalf of Dr. Dulari Gupta, Dr. Anup, and team members in Bharati Vidyapit Medical College, I thank you all for giving us this opportunity to present a case in this prestigious webinar series, which are very exciting to see. The video is very, very good, and so many secrets have been unraveled. So today's case, once the case is known, it's very easy to understand. But as the case evolves in an emergency situation over 4 or 5 days, the climax and what are the thinking that goes into this solving this puzzle and how it presented, we'll be presenting this case. And Dr. Anup will present the case, and I will be giving some clinical comments, and Dr. Dulari Gupta will discuss the case along with the review of literature. Dr. Anup, you can start your presentation.
Yes. Hello, I'm audible?
Yes.
Good evening, sir. Good evening, all my teachers and my friends. I'm going to present a case of CBSE. My patient is 22-year-old right-handed marine male who was currently was unemployed and had came to the Pune around a month back in search of a job. He had presented in emergency with a complaint of headache since 1 day and altered sensorium since around 7 hours. He was apparently all right around 1 day back when he developed headache, which was holocranial, moderate in intensity, and throbbing of type, for which he was taking rest and was not shown to any doctor or physician. And on the next day, he did not go out to accompany his relatives at work. At around 1 p.m., he spoke to the spoke to the wife on the phone, and after that, he did not respond to the repeated calls by his relatives. After that, around 7 p.m., his relatives forcefully opened the door and found him lying on the floor, semi-conscious in a pool of vomit. Then the relatives had taken him to the local hospital. During the transport, he had one episode of seizure, followed by second episode of seizure in the hospital. He was managed conservatively and referred to the Bharti Hospital for further management. On arrival in emergency at Bharti Hospital, he had one more episode of seizure, for which he had received lorazepam for termination of the seizure and was loaded with levetiracetam. He, in view of his low GCS and to avoid aspiration, he was intubated. Yes. So past medical history, he had accident around 4 years back, for which he had that time he had maxillary fracture and was managed conservatively. He had no history of seizure in the past, no history of alcohol intake or loose motion. He had no history of ear discharge or clear fluid from the nasal. He had no history of fever, no history of photophobia, no history of liver or renal dysfunction. He was not a known diabetic or hypertensive. Personal history: he had no addiction. He had mixed diet, sleep, bowel bladder were normal. Family history: non-contributory. So summary: 21-year-old male presented with one history of headache, altered sensorium of unknown duration, around 7 hours, and recurrent seizures, around 3 seizures in next 6 hours, with no history of fever. He had presented to the Bharti Hospital within around 12 hours of the onset. He had no any other comorbidities, so cause was under evaluation.
So, viewers and the colleagues, we had a very stormy, short, rapidly progressive illness. And morning he developed headache, by evening altered sensorium and recurrent seizure. So the main 3 clinical features are headache, altered sensorium, and recurrent seizures. And it is afebrile, and absolutely historically there is no other localization. As you all know, headache is mainly due to pain sensitive structures in the cranium, and these will be the blood vessels, the dural venous sinuses, the dura mater, proximal parts of the pial vessels, also a large blood vessels inside, trigeminal nerve endings onto the dura and blood vessels. All these things can cause pain. So this is a very short pain, and there is a red flag attached to it. That means a sinister type of headache. The second most important thing he had was altered sensorium. He was lying in a cesspool of vomiters. That means there is a scope for aspiration here. And altered sensorium, as you all know, it can be of 2 reasons: either from the affliction of a reticular activating system, or because of bilateral cerebral hemispheric dysfunction due to multiple synaptic dysfunctions. But here, there was no indication, there was no history of any seizures except the past history he had of a road traffic accident. So with these few clues, we had to carry forward this case for investigations, and he pursued a very stormy course in the next few days and puzzled us because of the clinical findings which Dr. Anup is going to show you. And there's a lot of confusion. What could be the etiology for this presentation in a 21-year-old man who had come to Pune in search of a job 1 month prior and had only history of headaches since morning. Dr. Anup, you can carry on with the presentation now.
Yes, sir. Sir, so on day 0, on examination, patient's vitals were normal. He was afebrile, BP and pulses were normal. General examination, GCS, no spontaneous eye opening, no verbal response on painful stimulation. He was making random movement on painful stimuli. So he was E1, V1 and M4. Cranial nerves, no persistent gaze deviation. He had bilateral 1.5 mm equal and reactive pupils. Fundus could not be examined due to small pupil size. He had no facial deviation. On motor examination, there was no wasting. Tone was normal. Power, he was moving all 4 limbs to pain. Deep reflexor scale 2+, plantar was flexor bilaterally. On sensory examination, he had pain on painful stimulation. He was moving his limbs, but detailed evaluation could not be possible even for cerebellar examination. No feature of meningeal irritation. Skull and spine was normal. So in a summary of history and examination, he was the same. He was 21-year-old male, presented with only one history of headache, altered sensorium, recurrent seizure, with no history of fever and no other comorbidities. So functionally, it is an encephalopathy with no localization, except holocranial headache, query because of raised ICP. We could not localize the encephalopathy. Non-traumatic coma without localization was a possibility.
You carry on with your presentation.
Yes, sir. Thank you. So in emergency department, we did urgent CT brain. CT brain suggests no parenchymal lesion, except we could see there is hypertense lesion in the superior sagittal sinus, as indicated in the arrow. So it was superior sagittal sinus thrombosis. So we confirmed with the venography. MR venogram was done. It was suggestive of superior sagittal sinus complete thrombosis, transverse sinus thrombosis, and sigmoid sinus thrombosis on the left side. So we had provisional diagnosis of cerebral venous sinus thrombosis, but the cause was yet to be found out. So on the next day, day 1, patient remained unconscious. His GCS was E1, VT, M4. He was already started on heparin, anti-epileptic, and mannitol. Investigation had showed leukocytosis. It was sort of reactive leukocytosis. Sodium was normal, electrolytes were all normal. Platelets were 1.4 lakh, and homocysteine was 45. It was raised. So we thought homocysteine as one of the cause for the CVST. On day 2, patient remained the same. The GCS were persisted as E1, VT, M4, bilateral small 1.5 mm pupil. He became febrile on the second day with intermittent fever spikes. Maximum was 1.101. We thought of aspiration pneumonitis, and we continued the measures. But the patient was still at low GCS. We thought of 3 main things. First, can it be post-ictal, or is it a non-convulsive status epilepticus, or any hemorrhagic infarct secondary to CVST? It could have been sedation due to lorazepam. Can there be any other third etiology? So on the day 2nd also, we repeated a CT scan to evaluate any parenchymal lesion. CT scan was done. It was suggestive of superior sagittal sinus thrombosis. That was the same, but we could not find any parenchymal bleed. There was small infarct in the caudate nucleus. But that was also not explaining the condition of the patient. So impression, it was acute non-hemorrhagic infarct in the left putamen and left high parietal region. Areas of restricted diffusion in the left high frontoparietal region. They were sort of secondary to cortical vein thrombosis. Still, the comatose condition was not explained in the imaging. So we continued the measures. On day 3, clinically he was E1, VT, M2. He was showing decorticate posturing, and also he had disconjugated eyes. Pupils were still small but reactive. We thought of intoxication, drug overdose. Patient still had fever. This time platelet were 45,000, TLC was 33,000. So it was a sepsis. Could it be because aspiration or any other reason? We planned for CSF blood because he had low platelet count. He was empirically started on antibiotics. So we started with ceftriaxone and vancomycin because he has sepsis, considering bacterial meningitis. But we started after sending culture. MRI brain was again repeated. This time there were multiple infarcts. The multiple infarct in the white matter bilaterally with multiple petechial hemorrhages, possibility of vasculitis need to be ruled out. Right thalamus shows minimal edema. There was mild prominence of both lateral ventricles stain, but there was no CSF pulse.
Dr. Anup, go back to the MRI, let them see once. You just
Yes,
keep
sir.
it for some time. So the new onset infarcts are seen. The first MRI, first CT scan was normal, and the individual has bilateral small pupils. The CSF could not be done, the low platelet count, and there is an elevation of procalcitonin also, I think, lab, which is going to show. So this is a picture why this individual has developed infarcts. They are not hemorrhagic infarcts, or they're not venous infarcts, as we often see in cerebral venous sinus thrombosis. Is there arterial involvement, venous involvement? Both arterial and venous. That's why vasculitis also was thought of. And initially, because of the raise in the TLC count, we thought of meningoencephalitis possibility also and started empirical treatment. Carry on.
Yes, sir. So we did platelet transfusion and we did CSF on the next day. CSF was suggestive of cells were 2000 cells per cubic millimeter. It was neutrophil predominant. Neutrophils were 90% and lymphocytes were 10%. Protein was raised. It was 285. The sugar was only 5 and blood concomitant sugar was 106. On day 4, fever was still persistent. Neurologically, he was E1, VT, M2, and the patient had still decorticate posturing. On investigation, platelets were still dropping. They were 27,000 and TLC was around 3,000. The CSF gram stain report had came. It had showed gram positive cocaine pair, as well as blood culture also showed Streptococcus pneumoniae, which was pan sensitive. So the meningitic dose of antibiotic were continued, but the patient had reaction to the vancomycin. So we discontinued the vancomycin, and he was again received the transfusion of platelets. On day 5, fever persisted. He was stuporous. He still had E1, VT, M1. He was wincing to deep sense of stimuli. The CSF culture did not show any growth, but the CSF analysis was done and the patient was already on antibiotics. The platelets were rising, minimal rise because of maybe transfusion. The platelets were 48,000 and TH was around 3,000. Echo was also done in view of any infective endocarditis, but it was normal. On day 4th, the procal was done. It was 92, so it was raised. As well as G-dimer was also done. It was 2,800. On day 6, the fever was still persistent, but GCS was E1, M1, and VT. On the day 6, on the round we saw the patient had gaze deviation to the left, as well as some nystagmus movement were present. We thought of non-convulsive status and we increased the dose of levetiracetam. But still in the afternoon, the patient had 2 more seizure episodes, and for which valproate was added. On day 7, fever was still persisting. There was no change in GCS. He was E1, M1, VT. Gaze was center. The seizures were controlled. The lab value showed increase in the platelet count. Sodium was 143. We continued with the injection ceftriaxone. We also added amikacin, considering more coverage. On day 8, fever started subsiding. The neurostatus had E2, M2, and VT. After initial storming course, he showed gradual improvement in the sensorium.
So you see, the crux of the problem is why this individual did not show improvement on day 2 or day 3. He had persistently altered sensorium and low GCS, and that could be because of is it meningoencephalitis? We could not explain how the infarcts have come. Is it vasculitis? So all these things could be resolved only when single donor platelets were given. The platelet count could be risen by about 20,000 and it cost 50,000. We could do a CSF examination that solved our problem. So this is a very, very, from the danger area phase, there is no injury as such on the ace, but we really had hyperhomocystinemia. Initially, it's an afebrile presentation, so we thought it could be hyperhomocystinemia that has led to cerebral venous sinus thrombosis. But the second day, the appearance of fever and the persistence of altered sensorium, despite antibiotic therapy and empirical nature, though he did not show improvement. That's what led us to think that there's an underlying meningoencephalitis, and this is the typical picture of pyogenic meningitis. If a pyogenic meningitis occurs, altered sensorium on day 1, day 2, or day 3, you are sure it is pyogenic meningitis. As you see Thwaites criteria, where this pyogenic meningitis is less likely, altered sensorium develops 6 days later. So we have correctly guessed it. We tried isolating the organism, but we could not. So I think that's interesting for us because we could salvage this patient. In the end, it looks so simple, but those 7 days when he had stormy course, we were at our wits' end. What are we dealing with this young man who was intubated on arrival in Bharati Hospital with recurrent seizures? There is no evidence of herpes simplex encephalitis, or EEG was not showing anything except generalized slowing. So whole hell broke loose in a few days, but slowly, everything settled. I think we can carry on with our presentation.
Yes, sir. So after 7 days, patient started responding well to the antibiotic and with anticoagulation. Gradually, the patient power started improving. On day 24, it was right upper limb was 5, lower limb was 4, left upper limb was 3, and left lower limb was around 4. He had required some support to walk. On day 16, we did an MRI to recheck as an academic purpose. So on MRI, there was still a new infarct on the left MCA territory. Even after the patient was improved, the patient still had new infarct. Patient was discharged on day 24 on warfarin, valproate, and levetiracetam.
Okay, I think Dr. Dulari, you can take over for the review of literature and discussion. Dr. Dulari Gupta, are you there?
Yes.
Please start.
It's not allowing me to share the screen.
Oh, shall I? Dr. Haley, will you please help her? Yeah. Initially, we thought of telling a few comments on the clinical presentation. Can I have the next slide? Yeah, the first and foremost, what we thought is that the arousal and awareness of an individual, which was affected in this case, and usually these are mediated by the bottom-up ascending reticular activating system, and also important is top-down frontoparietal and limbic attenuation, attention modulation. So these two things will keep awake and arousal intact in a normal person. Next. You can move the
Sorry.
slide, please.
Yes, there's some problem with this. Yes.
Yeah, there are a lot of neural networks that can be disturbed because of many reasons. Yes. So this network architecture is depicted here, which can get disturbed. Next. And you can go on. This just will pass on these networks. Okay. And we are bombarded by sensory stimuli that we filter based on salience, but we only focus what is important for us. That particular faculty was affected in this individual. Next. Next. So if you look at the areas that are damaged, the bottom up ascending reticular activating system is affected whenever there is any pathology in the brainstem. The top down frontoparietal and limbic attention modulation is affected, any disturbing the networks, and then you have attention problems and again disturbance of arousal and awareness. Next. So second important aspect is, why did he lose consciousness? That brings us to the point of this age-old Monroe-Kelly principle, which says that the cranium and the CSF and the brain parenchyma, which are about 1500 total, blood of 150, CSF 150, and brain parenchyma of 1200, they are always in a state of equilibrium in a rigid closed compartment. Next. What it does is it maintains the intracranial pressure at a balanced way between 50 to 150 next of cerebral perfusion pressure. So in this a non-expansile, non-contractible, freely communicating space, the pressure of fluid content is everywhere equal and directly proportional to the fluid volume. So most important of this is intracranial pressure, and it has got three components: the brain tissue, the blood, and the CSF. Next. Next. So this principle brings us to most important aspect, that is a cerebral perfusion pressure, which is intracranial pressure related. That means the mean arterial pressure minus intracranial pressure is the cerebral perfusion pressure, which will allow the blood into the brain parenchyma, because neurons cannot survive without a constant supply of oxygen and glucose. Next. 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 Go on. Just skip them. Right. So whenever this balance is settled, the intracranial pressure, which is normally about 15 millimeters of mercury, it increases. When there is an increase in the volume, it can be because of any reason, CSF, it can be because of occupying lesion, space occupying lesion. So there is a downward displacement of CSF, and there will be compensatory mechanisms that are able to maintain a normal intracranial pressure for any change in volume less than 100 to 120 ml. Next. Stage 2 is if the volume is greater than 100 120 ml, that means there is a drastic increase in ICP. There is a sudden increase. The balance is disturbed, and there will be ischemia of the brain and causing infarctions. Next. So the stage 3 is sustained increase in ICP when it is directly related to the systemic pressure, and body responses is totally shattered and is going to be the ultimate final stage. So that's how the intracranial pressure, which can be diagnosed by clinical features of headache, vomitings, visual disturbances, on examination, papilledema. But in this case, we could not, but there are no false localizing signs also. There is no other localizing sign except altered sensorium in this case. Next. Go on. This is the balance. Go on. So this is the drowsy and confused state. If ICP is 20 millimeters of mercury, and if it is 30 millimeters of mercury, the coma scale will be around 8 and less. So immediately we can give hyperventilation to reduce the carbon dioxide and bring down the pressure temporarily of about 5 hours. Next. So this equation we have already mentioned. We can go on skipping this. We'll finish off this. Next. Next. Right. So that's all I have to say. Finally, the cerebral neurons, which are fully dependent on cerebral blood flow, they require constant supply of oxygen and glucose, the point emphasized, and perfusion pressure should be optimal. Next. And what is the mechanism? The cerebral blood flow has to be maintained about 50 ml per 100 grams per minute. If it drops below 20 ml, then the physiological electrical function of the cells begins to fall. And if it is less than 50, then ischemia and reduced electrical activity sets in. So you can see the oxygen consumption, which is 3.5 ml per 100 grams per minute, and the stores will last only 10 seconds. The utilization of the glucose is 5 milligrams per 100 grams per minute, and it lasts only for 2 minutes. That's why this individual had infarcts at various areas, and because of one of these pathophysiological mechanisms on how this has happened in this particular case will be dealt by Dr. Dulari Gupta in her discussion. Carry on.
Good evening, everyone. On the onset, I'd like to thank Godhi sir and Lakshmi Narasimhan sir for the opportunity to present in this forum. One second. So, as you've seen, this was a case of infective CVT, and infections constitute about 6 to 12% of all etiologies of CVT. So, I'll be going over the literature of pneumococcal meningitis with its association with cerebral venous sinus thrombosis. So in this paper, it's a prospective nationwide study on bacterial meningitis spreading over 12 years from the Netherlands. And in this, they found totally, they followed up 2,220 cases of bacterial meningitis, out of which 26 developed CVT. So that's around 1% who developed CVT. The commonest infections were sinusitis and otitis media in 67%. And they found that patients with CVT were more likely to have coma as well as more likely to have focal neurological deficits. Parenchymal lesions were seen in 46% of those with CVT, out of which 8 were specific for CVT. 8% was specific for CVT. And the transverse sinus was the most frequently thrombosed in around 69%. Strep pneumonia was the commonest pathogen implicated in 65%. 44% of these patients received anticoagulation with heparin, and none of them developed any intracerebral hemorrhage while being on heparin. Low GCS recorded as a GCS less than 5 was seen in 54%, and death was recorded in 15%, so quite high mortality. This is another similar study from India. They have looked at all the cases of CVT retrospectively from 2022 to 2017 in CMC Vellore. They had a total of 238 cases of CVT, out of which 22 had CVT secondary to a bacterial infection. So the focus of infection, they found 3 foci: pyogenic meningitis in 54%, parameningeal focus, especially ENT causes, in 40%, and bacterial sepsis from a remote source in 4.5%. The presenting features were fever in 77%, headache in 72%, and depressed sensorium. In this study also, the transverse sinus was the most commonly involved in around 50%. All patients received appropriate antibiotics, and 50% also received anticoagulation. In hospital mortality was also 9%. So this is a breakup of organisms. When we are looking at pyogenic CVT with meningitis, similar to the case that we presented, strep pneumonia was seen in 2, Klebsiella pneumoniae in 1, Streptococcus suis in 1, and cultures were negative in 7 of these patients. So this is another retrospective study of 87 consecutive cases of pneumococcal meningitis spread over a period of 17 years from Germany. Meningitis associated intracranial complications were seen in around 74%, which is very high, and systemic complications were seen in 37%. Out of those with intracranial complications, arterial infarcts were seen in 21%, whereas venous thrombosis was seen in 10.3%. Diffuse cerebral edema was seen in 28%, similar to our patient, hydrocephalus in 16.1%, and intracranial hemorrhage was seen in 9%. Pneumococcal sepsis meningitis with CVT is not just restricted to adults. This is a case report from JIPMER in which a 35-year-old infant presented with fever, poor feeding, and lethargy. They were diagnosed to have pneumococcal meningitis and received appropriate antibiotics. After completing the course of antibiotics, the infant continued to have seizures, and repeat imaging showed superior sagittal sinus, right transverse, and frontal cortical venous sinus. The possible pathogenesis of the CVT, they have thought of vasculitis as well as local bacterial invasion, which triggers release of procoagulant and antifibrinolytic factors. In the Netherlands, they've had lots of prospective community-based studies looking at pneumococcal meningitis, and this is comparing two periods, 1998 to 2002 and between 2006 to 2018. Totally, they have documented around 1,816 episodes of meningitis. At presentation and admission, CVT was seen in 22 cases or 1%, and delayed cerebral thrombosis occurred in 29 further patients or 2%, out of which 15 of them died, those who had delayed CVT. I'll also give a review of literature for all the pneumococcal meningitis with ischemic infarcts. So again, as I said, many studies from the Netherlands. This is a prospective study from October 1998 to 2002. They've recorded 352 episodes of community-acquired pneumococcal meningitis, and intracranial complications occurred in 39%. In-hospital mortality was 30%. They have not recorded any CVTs, but infarcts were present at admission in 9% and went on to develop during the course of hospitalization in a further 17%. So brain infarctions is what they have recorded. They have also recorded other abnormalities in around 8%, but nowhere in the article they have specified which. I'm wondering if some of them could have been cerebral venous sinus thrombosis. In the same article, they have recorded all the various risk factors for complications associated with pneumococcal meningitis. So advanced age, otitis or sinusitis, absence of rash, low GCS, tachycardia, positive blood culture, elevated ESR, thrombocytopenia, and low CSF white cell count. If you look at these, our patient didn't have any rash. He had low GCS and persistently low GCS. Blood culture was positive and grew pneumococcal pneumonia, and he had persistent thrombocytopenia. So he had 4 of these risk factors associated with pneumococcal meningitis. This is another study from Denmark. It's a retrospective study of all adults greater than 16 years with community-acquired meningitis from 1998 to 2010. Totally 152 episodes of meningitis were recorded. Strokes occurred in 22 or 14% of these patients. Ischemic strokes were seen in 15, hemorrhagic strokes in 3, and both ischemic and hemorrhagic strokes were seen in 4. Here too, the commonest organism implicated was strep pneumoniae in 14 cases or 64% of the total cases. They did not find any association between vascular risk factors and the occurrence of stroke. So the possible pathogenesis of stroke in bacterial meningitis has been postulated to be because of vasculitis, vasospasm, coagulopathy, or localized thrombosis. This is a case report from the Middle East of a 48-year-old Indian man with pneumococcal meningitis. He was quite unfortunate and had 4 quite devastating complications of pneumococcal meningitis all at once. He had post-infectious vasculitis with an infarct, intracranial abscess, hydrocephalus, as well as hearing loss. So this is a picture from the article showing an infarct in the left medial thalamus, hydrocephalus, and an involving cerebral abscess. In a review of complications of bacterial meningitis, they found that cerebrovascular disease was the commonest with around 10 to 30%. And here also similar mechanisms of ischemic stroke have been postulated to imply vasculitis, vasospasm, coagulopathy, infective endocarditis, which we tried to rule out in our patient. His echo was normal with no vegetations, and septic shock, which could lead to hypotension and watershed infarcts. They have also termed a new term called delayed cerebral infarction. So they've defined this as new onset of clinical worsening, any change in consciousness, or a new onset of a focal neurological deficit more than 6 or 7 days after the onset of bacterial meningitis, even when there is evidence of improving CSF parameters. And amongst the patients they studied, around 1 to 4% of cases of bacterial meningitis had presented with this delayed cerebral infarction. Possible causes were vasculopathy and hypercoagulation. I will hand over to Murthy sir.
Thank you, Dr. Dulari. And dear all, we have presented a case of CVST, which we thought is another mill case, and we keep seeing a lot of these cases post-COVID and during COVID. A lot of thrombosis cases are coming, and plus this person has hyperhomocystinemia, and at presentation he was afebrile. So this all culminated in starting the conventional CVST therapy with anticoagulations. Pneumococcal meningitis has been associated with CVT and ischemic strokes. We could think only retrospectively we became wise. In the course of on the day 3 or day 4, the patient could be diagnosed. Presenting the same patient has not been reported still now such a presentation. Even in the modern era, infections need to be remembered as a cause of CVT. In a patient with CVT without parenchymal hemorrhage, persistently low GCS should make us set for other causes like meningitis in this case. That's what is the main clinical clue for us. What is it? Why he's not waking up? We have treated many cases of CVST. They wake up, they are doing quite well. Why this particular individual on repeated second imaging or not showing any parenchymal damage is not waking up? What is the cause? And to make the matters more confusing, if we suspected aspiration pneumonitis because he was found unconscious for about 6 to 7 hours in a cesspool of vomitus, and some X-ray findings of doubtful nature prompted us to think in the line of aspiration pneumonitis, and bacterial meningitis didn't cross our mind in second day. But third day, when he is not waking up, that's the time we thought of this. There are some Q&A questions. Haley, are you going to tell us, or I have to open and see? I think I can open and see. Is there a need for continuing oral anticoagulation in these patients with acute bacterial meningitis, or is it because we found hyperhomocystinemia? Yes, infectious causes we usually don't give, but here hyperhomocystinemia is there. And to tell you the truth, initial 2 days, we did not know that there's an underlying bacterial meningitis. When sensorium is deteriorated in the absence of seizable structural lesions with multiple arterial infarcts, one should think of infection. That's true, but this infarction was detected on day 4, and we did one imaging on day 1, second imaging on day 2 when there was nothing. But infarcts in arterial and venous territories in an afebrile patient can be due to vasculitis of any nature, and vasculitis could be secondary or primary. So there was some hesitation in the first 2 days, but when the fever is persisting, then we could catch up to onsen. And we'll see some more questions. Role of warfarin, yes, it has to be continued. At what dose was the warfarin started? Usually we target around 2.5. How long do you give warfarin? At least for 3 months. And we have to again look for other causes, prothrombotic causes later on. And Dovax for CVT is not yet in vogue. So far, we know that paroxysmal atrial fibrillation we can give. And recently, we had a systematic review of meta-analysis we presented in stroke subsection. In fact, Dr. Dulari only did the journal club. You can see that paper. There is a case for starting them. And infection-related CVT, role of anticoagulation, again, repeatedly. And this, if it is only purely, only antibiotics will take care, as we treat in cavernous sinus thrombosis. Anything else? Any other questions?
Sir,
Yes,
sir, there
please.
is the chat box.
Ah.
Sir Krishnamurthy from Devangari, HOD of Neurology, has said that the fact that the need for continuation of anticoagulants because of hyperhomocystinemia.
Yeah, that's I have answered that already. I told
Yeah, you
him.
already said that. The second thing which he also said that one of the take-home messages, whenever the sizable structural lesion with multiple arterial infarcts, one should think of infection. And he has congratulated the presenters. Sir.
Dr. Lakshmi, you must have seen that we did a serial imaging on day 1, day 2, and day 4. The infarcts came in presence in day 4. So till that time there was a confusion. But we have suspected and started empirical treatment.
It's a very wonderful case. I really thank Professor Brigadier Professor Gorti and his team for this excellent presentation. And a couple of caveats which I just want for the sake of postgraduates. Among the infections in Plasmodium, the cerebral malaria is one of the important cause for venous thrombosis, which was presented by Professor Krishnamurthy Srinivas here and Professor K. Srinivasan from Madurai. Both of them have documented and have published articles on cerebral thrombosis and cerebral malaria. CVT on cerebral malaria is one of the infective causes, which they have 1970 articles. Both of them are, and one of the large series Professor K. Srinivas from Madurai has presented the malaria and CVT. That's one thing we want to add. Second thing is, for the sake of postgraduates, the flow in veins is axial, whereas the flow in arteries is laminar. That is why the thrombus in veins occupies the center, and that is exactly the reason why you get a empty delta sign. And whereas the flow in the arteries is thrombus is eccentric, and the flow is on the periphery, whereas the flow is in the periphery and the thrombus is in the axis. These are two caveats which I just wanted to add. And thank you for a wonderful session, sir. I request Professor Sudhir Shah to.
Sir, there are a couple of questions in this. Can bacterial meningitis cause vasculitis infarction after 3 weeks? Yes. Nowadays, this being described delayed infarctions. And another question: how long the anticonvulsants have to be continued? What we call these are the symptomatic seizures. So symptomatic seizures are treated only short duration up to 3 months to 6 months. Not if there is no parenchymal damage, there is no need to continue anticonvulsants. Right, sir.
Professor Gorti, may I ask you one question? Did you
Yes,
have
sir.
a chance to have the MRI angio or CT angio of this patient?
We have the MRI angio, sir. We showed, no? Well, the first thing which suspicion is on CT, there is a CT suspicion of immediately MRI angio has been done. The MRI angio has shown the evidence of transverse sinus thrombosis.
I saw the venogram, but I didn't see the arterial.
Arterial was not shown, but it is there. It's there, and there is no abnormality in that.
Because later on the 4th or 5th day, when you saw so many infarcts, I mean, it's a good idea to do. Because whether it is the cerebral perfusion pressure mechanism or whether it's a small vessel vasculitis or something else, that pathophysiology, I think one thing. And secondly, to this August audience, would you please clarify the current status of homocysteine vis-a-vis cerebral venous sinus thrombosis? What is the exact correlation of the homocysteine in the etiology for the venous thrombosis?
So, last 2 stations where I have worked, and is especially in Karnataka, where I worked in the last 3.5 years, we had just published one case series of 140 cases of cerebral venous sinus thrombosis, out of which hyperhomocystinemia is about 40 cases, sir. And so that is there. Now the mechanism is the coagulation pathway affliction, but this is there. Hyperhomocystinemia as a cause for cerebral venous thrombosis is very much. And post-COVID, we are now analyzing our series in this hospital, pre-COVID and post-COVID. Dr. Dulari is working on it. And there are a lot of cases of CVST in these months nowadays. That means there is a pro-thrombotic tendency in post-COVID. But hyperhomocystinemia in Maharashtra area is not as common as in Karnataka, but it is there. We are seeing cases.
So what level of homocysteine you are looking at?
Right, sir. Actually, I did one review. I mean, meta-analysis of homocysteine. Usually, importance is above 40, but people do take about 20. So, if it is more than 20, we become cautious. If more than 40, then it is definite, sir. There are
You
so
would
many
agree-
confounders.
Yeah, sir. Yeah. So you would agree that B12 deficiency is in an endemic proportion all over, at least in India, and the reverse correlation between B12 and homocysteine is another issue.
Yes.
So, most of our people, they do suffer from low B12, and many of them will ultimately have hyperhomocystinemia. It's not homocystinuria, but it's hyperhomocystinemia. Between the two, what do you think is the more important?
It is I mean, disease-wise, homocystinuria is another entity, but for us, the strokes and all important homocystinemia, hyperhomocystinemia is important if it crosses 40 or 35, 40. In there are about 5-6 case control studies, 5-6 retrospective studies, and all this joined together. This figure has come when the confounders have been ruled out.
And that is more true for cerebral venous sinus thrombosis, or you think it is also equally important for arterial thrombosis?
Arterial thrombosis slightly less common. All procoagulant abnormalities for arterial strokes are less common when compared to venous strokes. Even if you take protein C, protein S, antithrombin 3, all these deficiencies, though we keep testing, they constitute a minuscule causes in arterial strokes. But yes, primary systemic vasculitis can have both arterial and venous strokes, and CSF is the correct answer for that.
Sure. I think your message is loud and clear, and you have very politely confessed that in the first 2 days there was a little delay in the diagnosis for certain reasons, and why you were misguided. But overall, the case has been worked up fairly well, and the outcome, as long as outcome is great, I think one is always happy about that. But the message is clear that.
So there was some question here, why we didn't start antibiotics on day one. And one of the teachings from All Indian Institute of Medical Sciences for us is that you should have some evidence to start anything. Initial day one, there is no fever. There's nothing. He came with headache, CVST diagnosis. So we don't jump to antibiotic. We did a ENT checkup. Also, focus of infection was thought. Echo was done. So we didn't get a cause, any clue. But fever, second day, thought of aspiration because of wishy-washy findings on chest X-ray. The only clue was we got bilateral constricted pupils, and why they were constricted, we didn't know really. Then this altered sensorium, which persisted, prompted us to go for empirical treatment on CSF later on. I confess that. The initial 2 days was very miserable for till we got the correct diagnosis.
I think the course is very fulminant in this case, and probably that would be one way to think in terms of infective thrombosis, because usually we see little subacute course, so mild protracted. This is a very fulminant course. You would agree that?
That's why we got alerted on third day, sir. Third day, I was telling my team, this doesn't look like run-of-the-mill CVST. He is not regaining consciousness. I'm not comfortable. What are we dealing with? Are we dealing with any systemic vasculitis, or are we dealing with something else? And then the fever spike started coming, and it was good. Why constricted pupil in this case? And I really can't see. We were debating on this issue, and initially we thought, is he a drug addict? Has he taken any drugs? And we really couldn't explain. Well, the constricted pupils usually you see in bilateral central Horner's syndrome. So that was one thing which we thought, could it be because of brainstem infarction? Well, bilateral Horner syndrome, central Horner's can have constricted pupils. because of the paralysis of symbol.
So someone has asked about role of steroids.
Role of steroids in bacterial meningitis is just before you start antibiotics. You cannot start afterwards, and you give, there is a evidence for intravenous dexamethasone as soon as you suspect bacterial meningitis and you do a CSF. Before giving first dose of antibiotic, you have to administer steroids, because the closed CSF space, if the bacteria cell lysis takes place, and there will be a lot of secretion of cytokines and inflammatory mediator, which will cause havoc. So the dexamethasone will prevent this. It has to be given 4 times a day for 72 hours, and you have to do a repeat CSF after 7 days to rule out the persistent infection. In tubercular meningitis, we follow dexamethasone and Thwaites criteria.
So also steroids for vasculitis, infection associated vasculitis.
Infection associated vasculitis, there is I have no, I think there's no role about it. There's no role. It's only antibiotics.
So someone's asked, how long should we give anticoagulation?
Sir, can I add something, sir?
Yes.
Yes, sir.
Mycobacterium tuberculosis associated vasculitis.
We treat, that's what I said. Thwaites protocol we use for tubercular meningitis. It is a known thing. We use 0.4 milligrams.
Well, I just wanted to answer that for tuberculosis, Mycobacterium tuberculosis associated vasculitis, the one of the drug of choice is thalidomide, as well
Thalidomide, okay.
thalidomide, optochiasmatic arachnoiditis, and the microvascular infarcts, which you develop during the treatment. Because the mechanism is tumor necrosis factor is one of the important thing, and TNF antagonism helps.
Yeah, that's true. But it's a known thing that we follow 0.4 milligram per kg body weight of dexamethasone for 7 days, followed by 0.3, 0.2, 0.1 over 4 weeks. We cover with steroids tubercular treatment in tubercular meningitis. But in bacterial meningitis, vasculitis, and steroids are not used.
So another question about how long do we plan to give anticoagulation, and do we need to do a MR venogram before stopping anticoagulation?
The recanalization may not take place, but usually if there is, usually the anticoagulation is 3 months to 6 months time. You start looking for procoagulant states, and then if you find one, the treatment will be for a longer time, for an indefinite time.
So what is the expected pupil finding for CVT?
Expected pupil finding?
Yes, sir.
If there is a raised ICP and thalamic pupils, there will be disconjugate gaze and bilateral constricted pupil in central horners. These are the things which can happen. If there's a false localizing sign, there can be 6th nerve and 3rd nerve palsies. So these are the things which usually come across.
So role of Aztreonam ceftazidime in pseudomonal post-op meningitis.
Ceftazidime. See, whenever you have nosocomial meningitis, usually it's a 4th generation cephalosporins, aminoglycosides, methicillin-resistant penicillin, and as well as ampicillin, the 4 drugs that are combination is given.
Someone has asked if the family members were screened for hyperhomocystinemia.
We get so many cases of hyperhomocystinemia that we are not doing that, but we do for protein C and protein S, and the family member screening will be done, but not for hyperhomocystinemia. Unless we have 2-3 cases from the same family has same problem.
Why did decorticate posturing occur in this patient?
That's decorticate localization is cerebral hemispheres. If there is a lot of cerebral edema, you'll get decorticate posturing. If it is mid-collicular level, it will be decerebrate posturing.
That's all for now, sir.
Thank you.
Which they asked is the role of acetazolamide, mannitol, or for the ICT, but I think decompressive craniotomy is the choice, not the.
Yeah, we can try
How
3% sodium chloride and
raise-
mannitol, but if there is no response, decompressive hemicraniectomy is done. Then nowadays they are doing intra-arterial, intravenous thrombolytic therapy, removal of thrombus, and if there are facilities, there are people who are doing that also.
Yes, sir. I think we have done with all the questions, sir.
Oh, nice. It's a wonderful experience, Dr. Lakshmi and Dr. Shah. And
We
thankful-
should thank you so much, sir, for sharing a wonderful case. Every episode takes us to a next higher level. Everybody tries to set a different benchmark, and we are honored to have your presence, sir. We are grateful to you.
Thank you,
And,
Dr. Lakshmi.
Sir, Professor Sudhir, sir, you want to add anything, or shall we hand over the mic to Arun Chadda, sir? Hello?
You have summarized everything, and I agree, concur to what all you said. It was a very good case with some basic learning also and some advanced learning from pathophysiology viewpoint. I think this looking simple case has so many different aspects that requires to be properly understood. I would really congratulate Brigadier SP Gorti Sahab and his team for this wonderful presentation. Dr. Lakshmi, do you have announcement for the next?
I'll finalize it, but it is as scheduled on the last Fridays.
Yeah, that's right. As usual, we will be meeting for the 25th episode on the last Friday of the month of July, and we hope that delegates will continue their support in the coming whole year. Thank you very much to each and everyone, and over to Mr. Chadda.
Thank you, sir. Thank you very much.
Ali?
Yes, sir. Good evening, all. It was indeed a wonderful case presentation. With this, we are at the end of 24th session of Secrets of Neurology web series, one of the longest running web series in India till date. I, Heli Gadani, on behalf of Indus Pharmaceuticals, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence in the last 24 months. It's audiences like you that makes presentation awesome. We are eternally grateful and thankful for making us reach this milestone, and we hope to have your support in the coming years as well. I would like to thank our honorable course directors, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir, for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DNB students. We are very thankful to young neurologist Dr. Anup Bende sir for presenting the excellent and unique case. Further to this, I would also like to thank Dr. Dulai Gupta ma'am for taking the discussion further. Thanks to Dr. Brigadier Shankar Prasad Gorti sir, HOD, Bharati Vidyapet, for providing important learning points and the proceedings of this unique case along with the expert comments. The entire presentation will be very extremely helpful and informative to all the participants. Once again, thank you all delegates for your gracious presence and patience, and I wish you a very good night with a hope to meet you again on 29 July with yet another most awaited session of Secrets of Neurology. Till then, stay safe and take care. Thank you so much.
Good night. Good night, everybody.
Good night.
Good night, sir. Good night.
Thank you. Thank you, sir.
Again,
Thank you
thank
very
you very much.
Thank you. Thank you very much.
Thank you,
sir.
Lakshmi. Good night.
Thank you. Good night, sir. Rohit, we can end.